Good afternoon, everyone, and welcome to the first in a series of webinars from Art of Surgery. I'm your host, Dr. Reaud Gafoor, Managing Director at Art of Surgery. First, I'd like to apologize for the late start. We've had some internet issues that were beyond our control, but I thank you for your patience, and I promise you what will be a very informative and exciting presentation. Today, we hope to give the Jamaican public an insider's view of the innovative options available for those who suffer from breast cancer. It's the most common of all cancers in Jamaican women and remains the leading cause of cancer-related death in women in Jamaica. It tends to be more aggressive, or a more aggressive form of disease that is associated with earlier age at diagnosis and advanced stage at presentation compared to women in developing countries. In the developed countries. Our topic is management of breast cancer, screening, surgery, and reconstruction. Bringing you their insights will be our panel, Drs. Patrick Bhoorasingh, Jason Copeland, and Raj Venugopaul. These doctors are helping breast cancer patients in Jamaica with the latest procedures and technologies at Art of Surgery. This webinar is intended to give people who suffer from, as well as those who treat this terrible disease, the support and information that they need. Knowing the options and where to find the resources will help them make informed decisions. By their nature, these presentations are graphic, and such images may be disturbing to some. We ask that you take the necessary precautions. At the end, there will be a 10-minute Q&A, question and answer period. Thanks for joining us, and we hope that today's webinar shed some light on this health challenge in Jamaica. Dr. Patrick Bhoorasingh is the first presenter, and he's also the moderator for this webinar. He needs no introduction to anyone who's familiar with the medical world in Jamaica. He is a past senior medical officer and consultant surgeon at the Kingston Public Hospital and associate lecturer at University of the West Indies. He earned his doctorate of medicine in general surgery in 1987 and fellowship of the American College of Surgeons in 1992. He has a diploma in early gastric bypass, and he has publications in laparoscopic cholecystectomy, patent ductus arteriosus, esophageal varices, among other topics. I now turn you over to Dr. Bhoorasingh.
Thank you, Dr. Gafoor. So we're going to start off with the surgical aspect of breast cancer. I'm going to try and separate it into surgery alone because it would take a long time to really include other disciplines. So we go a little bit in the history of breast cancer. And breast cancer was recognized quite early, 3,000, 2,500 years before Christ. It was described by Egyptians because they were the only people writing at that time. So, but I'm sure it was in the world, it was worldwide. It was recognized that it's really a disease that was incurable, and it was treated by just local excision and leaving in the womb, and most of the treatment was directed at prayers and offerings to the gods. But the first person, really, 1894, Halsted devised this operation. in order to cure breast cancer. It's called a radical mastectomy. Radical mastectomy, from history, it drives fear into a lot of individuals. It was associated with significant morbidity because they had to take off a significant amount of muscles of the chest wall along with the cancer. Sometimes there were nerve injuries, and it has to be done by a skillful surgeon because there was significant dissection and excision. It was a right prescription for the time that it was done. And it was the right prescription at the time, and it achieved cure in many patients. Other surgeons thought that they could do better, and they did what we call extended radical mastectomy. And that was also quite disfiguring. So there was, remember, at that time, there was no radiotherapy, there was no chemotherapy or hormonal therapy. So it was just surgical excision. And you must really congratulate William Halstead for devising this surgery. It is not done today, thankfully, because there are other things that came about. Now, we are only able to improve on Halstead's performance because of advances around breast cancer. We're not going to talk about these advances too much, except to mention them because we don't have the time to go through them. Imaging, chemotherapy, radiotherapy, hormonal effects, all those helped to improve the surgery of breast cancer. So, Patey and Handley thought they could improve on the morbidity associated with breast cancer. So they devised this surgery, modified radical mastectomy. It is still done today, but with a lot of criticism by older surgeons who did the radical mastectomy. They said that it is not cancer curing. You have to go radical mastectomy. And the criticism was mainly around lack of getting into the, what we call axilla where we describe as nodes. You couldn't get to the axilla without taking the muscles. And even when the muscle was taken, they said they could take part of the muscle. People weren't happy with that. But they had to do a lot of it to preserve a lot of function and decrease morbidity. And this operation is still being done today. It's still relevant in our situation. If you should compare radical mastectomy versus the modified entity, they are comparable in some of what is taken. But the most important aspect of it is that the disfiguring of the body wall, but that in the modified radical, the muscles were preserved and the axillary nodes weren't taken as extensive as in the radical aspect. Okay, so if you think there was criticism about doing less than radical mastectomy and modified radical mastectomy, in 1989, Professor Bernard Fisher thought that he could improve on the cosmesis of mastectomy and curing breast cancer. He devised this operation called QUART, that's quadrantectomy, axillary dissection and radiation. What does that is do what we call lumpectomy. Take out the tumor along with a piece of the breast and leave much of the breast behind. And there was a lot of criticism from other surgeons that it is malpractice, and Bernard Fisher had to go through a lot of soul searching in order to press on with that technique. And it came on, a lot of patients came to their doctors. I just want to I don't want to take off the whole breast. I want to take off a part of the breast and still maintain my breast. And in the end, it came out that this was really the right way to go. Of course, there are exceptions to the rule. Not all patients could have that operation, but of course, it was relevant for a lot of patients. The next part of the controversy for breast cancer is the area what we call the nodes. We talk about axillary nodes. It's for the uninformed, it's really some structures in the armpit of the relevant breast. We need to have knowledge about the nodes under the armpit in all the operations, whether it's going to be radical mastectomy, modified radical, or the quart technique. We need to know what is happening to the axillary node, because it does influence the prognosis and, of course, the therapy. And taking the axillary node it's really quite within the armamentarium of the surgeon, the general surgeons. But for the patient, it does leave the patient with significant morbidity because the nodes, the axilla removes a lot of tissue fluid from the breast and tissue fluid from the relevant arm, and there's significant edema, pain in the arm, not in all instances. So we have to have the axillary information, but at the same time, the information can lead to cure, but of course it leads to morbidity. So we want to find out how much axillary nodes do we need. Because in instances where the nodes are not involved, you don't have to take it. If the nodes are involved, then you do take it and do other things like radiation. So we want to know how much node do we need to take. So the sentinel node technique was devised, and that made us recognize which node, just one node, you take one node, analyze it, and if it's not involved with cancer, you do not take the other nodes, and the patient is spared the morbidity. If that one node is involved, then you can go ahead and take the other nodes in order to cure the patient. But of course, there are other things about analyzing the sentinel node, such as the pathological analysis. Now, with all that in place, then suddenly there are more confusion, because with breast cancer, we know there's stage 1 to 4. All of a sudden, there's appear with imaging, of course, more imaging, we discovered this thing called DCIS, ductal carcinoma in situ. Now, this is the disease, very early breast cancer. And as a matter of fact, some persons don't think it is cancer because it is not invasive cancer. As it stands, this will not kill the patient. It is really very early cancer, and we describe it as stage 0 disease. And basically, it cannot be felt. Most of them cannot be felt. They are really found on imaging. So it's like a ghost. You see it on a picture, but you can't feel it. And some, especially insurance company, would not compensate you for having DCIS because they think it's not cancer. But what about DCIS is important. It's really a dilemma for both the patient and the surgeon, because as I mentioned before, you can't feel it and it does not spread. It's difficult to convince a patient that it's something you can't feel, you have to do surgery on, and there's no spread at all. But prediction, that is what we do. We cannot predict. Some will progress to breast cancer, invasive breast cancer, and spread and metastasize. Some will never spread. You can, if you take out that single focus of DCIS, you can cure the patient That is if you have a single focus, which you can take out. Sometimes it involves the whole breast. So you mean you have to lose the breast also if you have extensive DCIS. Sometimes if the focus is small, you may need radiation to go along with it. Sometimes not. Sometimes it's hormonal therapy. So the problem is for the surgeon to explain to the patient which one will become cancer, which one you have to take the breast, which one you can just take part of the breast, which one you'll have to take the nodes also. And it does create a dilemma. So we have some VNPI, Van Nuys Prognostic Index, as it relates to DCIS. And it depends on the score. Is to make life easier for the surgeon and prevent you from having to defend it for litigation. You use the index to determine who needs what. And based on that, some pathological findings, the age of the patient, and how large that focus of DCIS is, then you can defend what you do. And depends on the score you get. The score will tell you, you see, some you just have the low score ones, you have excision alone. Depends on how far or much tissue you take. You may or may not need radiation. And of course, as I mentioned, high score or large ones, you may just need a mastectomy. But the main thing that DCIS does not metastasize is just a local disease. And the other thing, pathologically, you have to analyze, you cannot analyze the whole DCIS because there's what we call micro-invasion. You may have invasion in a small portion. So it makes it hard to decide. The other aspect of breast cancer is new techniques to diagnose breast cancer, biopsy techniques. The general rule is that you should not really cut the breast until you know what you're dealing with. So not cutting the breast, then we have minimal invasive ways in order to find out what we have in the breast. The old method of incisional, excisional is hardly ever used. Sometimes you have to resort to it if you don't have the information from the newer techniques. So if you look at the picture, image guided, use an ultrasound or the mammogram or MRI to biopsy what is inside the breast. And that is just a needle stick and you get the information straight off. And you can use what we call a core needle or fine needle in order to get the information. And of course, the lower picture, the hook wire excision, is that can be curative, especially for DCIS and in some lesions. You put a wire into the breast by a mammogram or MRI or by ultrasound, and the wire guides your excision, and you can take out enough to cure the patient, and that is all you need in some instances, but not in all. And finally, which is much more confusion, is genetic considerations. We all know about these BRCA from the publication, but BRCA is 1 and 2 is not the only consideration for breast cancer in terms of genetic information. Sometimes you have genetic counseling necessary. The problem with genetics is that you must remember that there's a familial association. There's breast cancer in the male as well as female. So if you have a genetic inheritance in a family, you may have to screen the male. And genetic information may involve not only breast cancer, but ovarian cancer, prostate cancer, and pancreatic cancer. And of course, the relevance of genetic information. Some patients will or may get breast cancer in the opposite breast, and they have to make a decision between the doctor and themselves and with genetic counseling, whether you want to take both breasts, although it's not involved with cancer, or you may just do one. So I'm going to hand you over now to my other presenters. First of all, we're going to have Dr. Jason Copeland. He's the breast oncologist at the Kingston Hospital. He's a medical director for the first breast oncology unit at the Kingston Public Hospital. And he's a consultant surgeon there also. He was trained at, well, Arden High School, but more so at the University of the West Indies, where he did postgrad surgery, and he did fellowship in breast oncology at Rosewell Center in the US. Okay, Dr. Copeland will tell us about genetic, well, some aspects of breast cancer as seen in Jamaica. The next presenter, the other presenter will be Dr. Raj Venugopal. He's a consultant plastic surgeon. He's the head of the plastic surgery department of the University of the West Indies. He was trained at the University of the West Indies. He did a fellowship in plastic surgery at University of Miami. And he will talk about reconstruction of the breast to make it cosmetically pleasing after mutilating surgery by the general surgeon. So I'll hand over to Dr. Copeland, who will proceed with the next presentation.
Thank you, Dr. Bhoorasingh, and thank you guys for having me. My part of the presentation, I will be speaking about breast cancer in Jamaica. Now, this will primarily be based on the Kingston Public Hospital Breast Cancer Registry from 2017-2018. I have no relevant disclosures for this presentation. So what we'll be looking at today is some of the clinical pathological determinants of breast cancer outcome. Now, the Kingston Public Hospital Breast Cancer Registry was started in 2018. We analyzed the first 14 months of the database, and what we found, we had approximately 101 patients with invasive breast cancer. 99 of these patients were females and only 2 patients were male. We used the American Cancer Society and the Surveillance Epidemiology and End Result database to compare with our findings to see how breast cancer in Jamaican females differed to breast cancer in the US. What did we find? Well, breast cancer in our population, in our females, they were younger, they had more aggressive biology, they had more advanced stage at the time of presentation. We also looked at different groups within our population. We looked at patients who were under the age of 50, arbitrarily a designation of young patients when it comes on to oncology. And what we found was that in the younger patients, they much more likely had nodal involvement with breast cancer. They also had more aggressive biology. Some of the other things that we found in the research was that the breast cancer mortality in Jamaica has been increasing in the last 20 to 25 years. This is not unique to the Jamaican population, as in the Caribbean as a region, in the last 25 years, we have the greatest increase in breast cancer mortality in the world. A second injury, I would say, is that the treatment of breast cancer in low and middle income countries such as Jamaica is often a bit more aggressive and more morbid. So the outcomes, especially of surgical therapy, sometimes can be quite disfiguring. So let's look at some of the results, some of the database. The Global Cancer Observatory in 2018 estimated that 25% of all cancers in females were breast cancer. By December of last year, when they updated their database, they found that more than a third of all cancers in Jamaican women were breast cancer. This is an incidence and mortality trend over the last 10 years. And what you can see is that the incidence of breast cancer has been increasing, and so too has the mortality. So what are some of the determinants of breast cancer outcome that we're going to talk about? Age, the grade or proliferation index, the tumor stage. More recently, we have been speaking about the intrinsic subtype or the molecular subtype of breast cancer. And in more high income countries, they've been incorporating genetic mutation, genomic testing as early determinants of how their breast cancer is treated. We will not speak about that today because this is not available to us currently. So let's look at age. When you look at this slide, what you can see is that the KPH patients are in the dark gray and the US patients are in the lighter gray. Now, the distribution of breast cancer in Jamaican females is a much younger age group than in the American population. The average age of breast cancer for us was 54 years in our study. And what that means is that half of the patients are presenting before the age of 54, and the other half is presenting after the age of 54. But beyond that, if you look, you'll see that the age group 45 to 54 has the highest incidence of breast cancer in our study. What that means is that any sort of policy that will be implemented for breast cancer, whether it's screening or otherwise, has to address this age group 45 to 54. And we'll speak a little bit about screening shortly. What are some of these implications for this age distribution? Well, one, there are implications for screening. When should we start screening? There are implications for breast cancer prognosis, or mortality rate has been increasing, and we know that breast cancer in the younger population is associated with a far more aggressive disease. The age standardized mortality rate is extremely high in the young patients. In fact, the Caribbean region has among the highest age standardized mortality rates for breast cancer in patients under 50. A lot of these women, young women, are in their reproductive and economic prime, and there's significant dysfunction with family life as well as with fertility. With so many of our patients presenting with breast cancer under age 50, there are implications for genetic testing as well. This is a population pyramid of Jamaica 2018. And on the right side of the pyramid, we have the female population. And what you'll find is that if you look for age group 40 up to 70, we have an estimated 300,000 women that fall in that age group. And this is the ideal age group for screening. Any effective breast cancer screening program should account for approximately 70% of those of the population that is eligible for screening, which means roughly 200 to 250,000 women per year. A study done by Suarez et al. In 2007 showed that an estimated only 5% of eligible women in Jamaica who are eligible for screening, were actually being screened. When we looked at our database at KPH, what we found was that for patients who had breast cancer, only 23% of those patients had any screening in the preceding 5 years. So obviously, we're not doing a lot when it comes down to breast cancer screening. Dr. Bhoorasingh had mentioned DCIS, and that is one of the things that you pick up in populations that are doing a lot of breast cancer screening. Our DCIS rate in our study was only 4%. If you look at the SER database, they were seeing 17, 18%. In many countries with national breast cancer screening programs, their DCIS rate is 20 and 25%. So this is a chart showing some of the screening recommendations for breast cancer. And I'll highlight the US Preventative Task Force recommendations. They recommend beginning breast cancer screening, mammographic screening at age 50, and that this should be done biennially, every other year. Now, from the age distribution of breast cancer in Jamaica, you would realize that this would not be an effective tool or effective screening recommendation to significantly affect breast cancer mortality in our population. Most of the other recommendations do accept that screening at age 40 is perhaps the better way to go. In fact, the prediction models that most of these guidelines have used show that screening commencing at age 40 actually has the best decrease in breast cancer mortality in any population. Let's look at another determinant of breast cancer outcome, and that's grade. Now, the grading of breast cancer obviously tells us how aggressive this cancer is likely to behave. We have the KPH database in blue and in orange, the SEER database. And all the study by Shirley et al. Is represented in gray. And what you'll see here is that low-grade breast cancer only accounted for 8% of the patients in our study. The majority of our patients either had intermediate or high-grade breast cancer. So what that points to is the fact that our breast cancer patients have more aggressive disease than what is seen in the US population. The study by Shirley et al. Actually has similar findings to what we found in our research. Let's look at the tumor stage, and this is the degree of spread of the breast cancer. 50% of our patients were early breast cancer, meaning stage 1 or stage 2. Contrast that with the SEER database, where 85% of their patients were early breast cancer. Obviously, with earlier breast cancer, at the time of diagnosis, the outcome, the prognosis is that much better. But this also speaks to something else, which we'll see in the other slide. When it came on to surgical therapy, 95% of our patients were being treated with mastectomy, the majority of which were unreconstructed. Now, with 50% of our patients presenting with early breast cancer, there's a significant opportunity here to de-escalate the morbidity of our surgical therapy. Only 5% of our patients actually had breast conservative surgery. Contrast that with the SEER database, where 62% of their patients were able to undergo breast conservation surgery. Axillary node mets, 50% of our patients were node negative on final histology. That all these patients, by and large, had axillary lymph node dissection, and 50% of them, there was no cancer in the axillary node. So what that means is that in 50% of cases, an axillary lymph node dissection was not beneficial, and the patient could have had a less morbid procedure, such as a sentinel lymph node biopsy. On the right-hand side of the slide, you'll see that the morbidity rates between sentinel lymph node biopsy and an axillary lymph node dissection are quite significantly different. Axillary lymph node dissection has roughly 2 to 3 times the lymphedema rates of a sentinel lymph node biopsy. So there are significant opportunities here, even in our research, that we can de-escalate the morbidity of surgical intervention in patients with early breast cancer. Now let's look at the intrinsic subtype. The determinants we looked at before, by and large, are prognostic factors. When we speak about the molecular subtype or the intrinsic subtype, we have both prognostic as well as predictive information. We can predict how that particular tumor may respond to therapy in terms of drug therapy. Now, the intrinsic subtypes are 4 main types: luminal A, B, HER2 positive, and triple negative. The luminal A type is usually the type with really good prognosis, and you will see that only 49% of our patients had this good prognostic type. Contrast with the SEER database, 66% of their patients had this good prognostic type. If you look at that mustard color, you'll find that 21% of our patients had triple negative breast cancer, which is an aggressive form of invasive breast cancer, twice the rate that was seen in the SEER database. So at a glance, you can see that we have a less favorable breast cancer type, and we have the more aggressive triple negative subtype. Again, any intervention that we're doing on a broad scale has to take into consideration the fact that we have high triple negative breast cancer rates, and that has to be addressed if we're going to decrease the breast cancer mortality. We did look at age groups, and we saw that patients who were under 50 actually had less of the luminal A subtype, which is a good prognostic type, and patients who were older had more of that good prognostic type. Now, the numbers were small, and hence the differences were not significant statistically, but we saw a trend of less luminal A type in patients who were young. So this is really a treatment table and is one that we use in the breast oncology clinic at KPH. And I'll speak primarily about that triple negative subtype. Now, what we have found more recently in a study called the CREATEX trial in 2017 is that for your triple negative population, if these patients are treated with chemotherapy before surgery, we're able to assess the response to treatment. Patients who do not respond well can be treated with additional therapy, primarily capecitabine, and that subgroup actually have an improved survival compared to the other groups if we are treated without neoadjuvant chemotherapy. So it's very important for patients with triple negative breast cancer, if they have stage 2 or stage 3 disease, that they do not go directly to surgery. These patients will be sequenced through a neoadjuvant chemotherapy, which is chemotherapy before surgery, then surgery, and then they can go on to additional therapy. Triple negative breast cancer with stage 1 may go directly to surgery. When we looked at the HER2 positive group, there were similar outcomes from a different trial, which is a Catherine trial, that showed that stage 2 and stage 3 HER2 positive breast cancer should better be treated or is better treated with neoadjuvant chemotherapy. And again, patients who do not respond well or tumors who do not respond well to that therapy can be given additional anti-HER2 therapy. When we look at the better prognostic type, the luminal A, luminal B type, we find that these patients with stage 1 and stage 2 can go directly to surgery. The stage 2 and stage 2B, and stage 3 can be separated into premenopausal and postmenopausal. Your premenopausal group benefits from neoadjuvant chemotherapy, while your postmenopausal can be given chemo or neoadjuvant endocrine therapy. They both work equally well. So look at a few cases of early breast cancer. This is a 57-year-old post-menopausal female with T1 breast cancer, stage 1 breast cancer, very early. She was hormone receptor positive at luminal A type. She was HER2 negative. She had a single focus of breast cancer at 10 o'clock, and she was desirous of conserving her breast. So we offered her breast conservative surgery along with sentinel lymph node biopsy. She was clinically node negative. In terms of her incision, we decided to go with an axillary incision where we could take the tumor out by dissecting towards the breast parenchyma, as well as perform the sentinel lymph node biopsy using a gamma detection tool. So this is the tumor that is out, oriented for margin assessment. We did our sentinel lymph node. The margins were negative, the lymph nodes were negative. She has healed pretty well. This is a month post-op. Her tumor is out. We were able to preserve this lady's breast, and she's now going on to have whole breast radiation therapy. The second case is another lady with early breast cancer. She was premenopausal, again, luminal A. She had a single focus of cancer at 12 o'clock position, which we confirmed an MRI because she had a dense breast. She also desired breast conservative surgery. She was clinically node negative. We offered her breast conservation plus sentinel lymph node biopsy. In her case, we went with periareolar incisions and removed the tumor out, oriented for margin assessment, closed the defect in the breast using dual plane mobilization techniques, closed the periareolar incision, and this is her a few weeks after surgery. Again, we were able to offer this patient breast conservative surgery and save her from a mastectomy. The margins were negative, lymph nodes were negative, and she's also moving on to have whole breast radiation surgery. So finally, what we recommend is that there needs to be more integrated breast cancer treatment facilities where we can have surgical oncology, medical oncology, radiation oncology, seeing these patients in an integrated fashion, not a fragmented fashion that exists in a lot of our centers. a national breast cancer screening program focusing on the diagnosis, early diagnosis of breast cancer, particularly in young patients. I believe the screening program has to start at 40, not at 50. There has to be significant institutional support to fund these programs. And of course, population awareness. Our research, though small, was in keeping with some of the previous research done on breast cancer in Jamaica and also showed stark differences between our population and that of the US. We believe that there are significant opportunities to de-escalate the morbidity of what we do in our surgical therapy for patients with early breast cancer. Thank you.
Good afternoon. Thank you, Dr. Bhoorasingh and Dr. Copeland, for giving us the opportunity to discuss this, and Dr. Gafoor for really putting this together. So the plan today is to really finish off this seminar with focus on reconstruction. Now, we all know that externally, what differs from a man and a woman is probably the breast. It symbolizes femininity, maternity, as well as sexuality. We've heard from Dr. Copeland and Dr. Bhoorasingh how the actual overall management is done, but I'm going to just emphasize this is a huge team which takes care of the patient, and it's a patient who is the focus of all of our attention. We all know that the breast is really 80% or more of fat, and the rest are made of the ducts which actually form the breast cancer. So it was fairly obvious to Dr. Zerny, one of our pioneers in surgery, who many things are named after, to take, a lipoma, which is that collection of fat, and put it under a mastectomy site. And that probably was the first recorded reconstruction. So when we see a patient, the choices offered are, do we do a mastectomy? Do we do breast conservation, as Dr. Copeland just spoke about, or do we do a mastectomy with reconstruction? So the choices are, first, the mastectomy, which is, as Dr. Bhoorasingh said, historically is the removal of the breast tissue as well as the nipple areolar complex, leading to a transverse or oblique scar on the chest wall. And Dr. Copeland has talked about breast conservation. And think of these patients having to have a lot of different stars to align to fit the bill. But as he had mentioned, the earlier the disease process, the more chances the stars can be aligned. This is always combined with radiation therapy. And as he had beautifully described, the conservation technique involves removing a small amount of breast tissue. But however, when large amounts are required to be removed from a cancer treatment point of view, we have to do some form of what we describe as oncoplastic techniques. And he described the displacement, which is really juggling the tissue which is left behind and trying to reconstruct that mound. Or thereby situations where their volume has to be brought in from externally. So this is an example of volume displacement similar to what Dr. Copeland has described. And this is what he had described, moving things from the inner or the medial quadrants or from the outer quadrants. In more complex cases, we do use modification of breast reduction or breast lift markings, as he outlined as well. So this is, again, a case where classically the reduction markings would be running vertically or down towards 6 o'clock, but the tumor is located in the outer quadrant. So there's a modification and the person ends up getting some form of a mastopexy or breast lift, but she opted not to do anything on the other side. And we'll discuss this later on. So in this patient, a large volume, almost the entire upper outer quadrant needs to be taken off. And she really was not interested in anything more disfiguring than a limited excision. So we had to use a little bit more of a displacement technique. Here, we're going to do a vertical reduction pattern, and that's going to give you this classical lollipop or short scar technique. And you can see that we've had to balance the other side to make sure that the volume match and aesthetic match is similar. So you can still see there is still some redundancy in the lower quadrant because that had to be moved up into the upper quadrant. Now, as Dr. Copeland has said, that part of the management of oncoplastic is to give radiation, and due to that radiation and the amount of tissue may be taken out can lead to distortion, and that can vary as high as 70% in some cases. This is an extreme case where you can see the nipple is pulled over to the lateral side or outside. And in this situation, we've got to move the nipple back to a more central position. We've got to also create tissue space to allow for that to occur. And this, we go to the back and we use a muscle called the latissimus dorsi, and we bring that to the front. And that is really the latissimus dorsi acting as that spacer in that breast. You can notice that there are markings done for a mastopexy on the opposite side, and which is also done at a much later stage when everything kind of settles down in terms of swelling and edema. So that could be 6 to 9 months later. And this is her after the mastopexy and the oncoplastic technique. So when a patient comes for reconstruction, we have to decide, are we going to do this immediately, or is this going to be a delayed procedure? So in a delayed reconstruction, historically, we thought that there had to be some form of safety measures. So they did studies and showed that it was actually very safe to offer immediate reconstruction when it was early breast disease. Now, one of the reasons for also offering delayed reconstruction was that if the patient had a period of loss, they would appreciate the reconstruction more. But this has really changed. But I'm going to still say that there's still an option for certain patients to have delayed reconstruction. Now, immediate reconstruction, this is going to offer better aesthetic results, better psychological outcomes, decreased number of surgical procedures. Obviously, that's going to improve financial benefits. I just heard about how gene testing is not just related to BRCA1 and 2, but the reason I have this slide is that once Angelina really made public what she was doing, there's been a general increase in doing double mastectomies. So breast reconstruction can be either done with using your own tissue or using prosthetics. Now, I always say this is a multi-stage journey, all right? So the autologous tissue, we just heard about you moving tissue from the back, and that's the latissimus. We can go to the abdomen where most of us have ample fat and try to transfer that. And we can actually also go to the gluteal area and transfer that as an area of soft tissue. Now, the latissimus dorsi, the problem here is that there's not much volume of fat on the back. So if your cup size is greater than A, you're probably going to need to augment that with a prosthetic reconstruction. But I probably have not done this technique for over 20 years because I feel that it should be either using one technique or the other. So the pedicle tram, which is probably the most common reconstruction that we do locally, is relying on the blood vessel called the superior epigastric going to one of the six-pack or the rectus muscles. We're going to take the area which would have been thrown away in an abdominoplasty. And that area which is mobilized along with the six-pack muscle, as you can see in this diagram, is transferred through a tunnel located up just under the breast and into the breast pocket. That area where the rectus muscle is opened is closed and reinforced with a mesh because one of the problems is abdominal weakness or a frank hernia. So in a free tram, we go to a bigger set of vessels, which is down at the bottom. And here you can see that those vessels are dissected out with a chunk of the muscle. And this was a classical free tram. And you're going to use those inferior epigastric vessels to reconnect using microsurgical technique into blood vessels in the chest in terms of the internal mammary or in the axilla, which would be the thoracodorsal vessels. The free tram obviously is a much longer surgical time. It is, because of microsurgical technique, it's more difficult, and it really requires potentially intense post-operative monitoring. It does have benefits of being able to transfer larger volumes of fat and maybe having less aesthetic bulges in the epigastric region. The deep inferior epigastric or perforator flap is probably the most common type of things that you will see in terms of advancement. But what in this operation, what's really done is that just the fat alone is taken. The muscle, as you can see here, is preserved. But the problem here is that this dissection can be quite tedious, and both this and going to the buttock area to transfer requires microsurgical. The buttock, is probably not going to be the first choice in our population because we're always trying to increase that volume. But it also creates a technical difficulty because you're going to have to reposition the patient twice. Now, this is our index patient with the mastectomy who's had a standard pedicle tram. You can see that both the volume and the surface area has been replaced with abdominal skin. Now, to improve aesthetics, Dr. Copeland and Dr. Bhoorasingh does remarkable stuff by preserving the skin pocket and taking out the entire breast tissue and the axillary nodes through a much limited incision. That's going to leave us basically an empty pocket to fill. So the other important thing is to remember the nipple. The nipple is part of the duct system, and oncologically thought it was important to take the nipple as a part of the oncological steps in this reconstruction. So this would be a person who we first started doing areola sparing. In other words, we would leave the dark area and just take the nipple, which could give you good aesthetic results. Then when we actually started pushing the boundary a little bit more, we said, let's leave the nipple, make sure that we sample under the nipple and make sure that there's no evidence of cancers. This is also for patients whose tumor is not anywhere close to the nipple. So this is a patient who's had again, a tram, and this incision was done through a lateral approach. You can do bilateral, as unfortunately in this patient, she had bilateral disease. You can see extensive skin changes on the left side. And on the left side, she had basically a standard mastectomy. On the right side, she basically had a nipple sparing mastectomy, also with the tram flap. But that tram flap now is hidden, and the only thing you're seeing is the regular breast envelope. The same fat, which increases as we eat, will continue to increase. So if the patient continues on their standard nutritional, you'll find that that tram can increase in size. Over the last 20 years, I've had 2 cases where we've done a tram, but one needs to know that once a tram is done, we cannot reconstruct the opposite side. And if that happens, we have to go with using a prosthetic technique. So prosthetic techniques, the advantage is there's a shorter operation, shorter recovery time, there's less scarring. It requires multiple operations, and you can get, scar tissue forming around these implants. And that's what's called capsular contracture. I think, if it's something sometimes like a keloid, some people will have good scar healing and others will get keloids. The wrinkling is something related to the implant quality itself. It's an expensive balloon, so it can deflate, it can rupture, you can have infection, and it can actually extrude due to some weakness in the skin. Before COVID broke out, what was really on the news was the very rare association of a very a lymphoma associated with breast implants. This was a very particular type of implants which have been removed from the market. So in terms of prosthetic reconstruction, we can do a single or a double stage. I tell patients sometimes, when you go in for the single stage, you're trying to hit a 6. Everything works out. It's great. Everybody's happy. You're a hero. But the problem is that you can get caught on the boundary if you have any problems with the external skin being lost, which is one of the problems when you do the nipple sparing and skin sparing techniques. So if you're doing a double stage, I feel that you were playing the ball on the ground towards the boundary. So much safer. And the implants, as we all know, is either filled with saline, which is what 80% of our body is made of salt water. So if there's a leak there, there's really no risk to the patient. Gummy bear, as people like to call it, or silicone gel implants have been improved, both from the fill as well as the shell that it has had. The gel has the advantage of having less rippling and supposed to feel more natural. So if we're doing a multi-stage, we put in an expander, which basically is a balloon with what we call a port. A port is a site to allow us to access the expander without damaging the shell. And we basically put these expanders classically under the muscle, but there can be situations where we put it on top of the muscle now. And we're basically going to fill, this is as an outpatient to get serial expansions of the skin. Now, this is a patient who's had a prosthetic reconstruction. She's had a vertical kind of marking. Immediately after surgery, you can see this wrinkling. You can see the outside of the drain, which is usually left in for over a week after these procedures. But you can realize we've filled up to about close to 400 cc's here, and she's got fairly good stretching of the skin. We're going to put a little fat into the upper area. And so this is her after the exchange, as well as a little bit of fat transfer. So one of the other advantages of a stage procedure is that you can actually go larger volume, as seen in this case. So in one stage, we have the blood supply going to the skin coming through the breast tissue. And when you do take out that breast tissue, you're basically knocking the main blood supply. So it's a reserve, and that's what the problem is. So we also try to fashion a pocket bra, and classically that this is, in the literature, you always talk about a dermal matrix being used to create that bra or sling. However, we've been have not at our disposal due to the extensive cost of these substitutes. So we've actually used an absorbable mesh to create that sling. The ideal patient for these one stage are relatively small volume breasts with minimal ptosis. So what makes immediate reconstruction difficult? If the breast volume is excessive, if there's a lot of fall in the breast, and your overall weight or body mass index is increased. So balancing is very important, because you notice that when we do reconstruction, the breasts tend to look a little bit younger than the non-operated side. So as a part of our second stage procedure, we'll probably do a mastopexy to try to get improvement here, obviously with a bit of fat grafting as well. So doing it at the second stage gives us the opportunity to really balance these patients properly. And that's important. So even though you're doing it in 2 stages, you're really stretching the operation and making it shorter in each stage, and allows you for better balancing. And in balancing, sometimes the patients opt to go larger, as in one of the previous cases. So balancing may require augmentation of the opposite side. The final step is really nipple reconstruction if it wasn't done before. And that's classically done with tattoo, or we use local tissues to create a nipple. We can never make it as good as God. And that's one of the reasons that we've pushed to preserve the nipple as well. We touch on fat grafting, and this is really a great armamentarium, because we're allowed to fix little defects and improve the patient's overall appearance. Radiation really doesn't go well with either technique. Implants fare much worse, a lot more scar tissue, and chance of getting the skin weakening and the implants extruding. So it's always harder to operate after radiation therapy. And if the implants are already in place, the chance of you getting more capsular contracture is higher. The final thing I would say is that same thing can happen in the autologous group, meaning your own tissue. But in this case, a benefit actually happened. The right side got radiated, and you can see the contracture has actually given her better form of the breast compared to the non-radiated side. And if you look at the scars, it actually also looks much better, which we all know from keloid therapy that we can get better scars with radiation. Finally, the option of an external prosthesis must always be mentioned. And we cannot thank Cancer Society and all of its team, especially the Reach for Recovery, which supports all of our patients and ourselves. And finally, remember the team involves the family who's going to provide support for the patient, but we also can talk about surveillance that Dr. Copeland did when we meet with the family as well. I'd like to thank you for your time, your attention, and the plastic surgical team for assisting in putting this presentation together. Thank you.
Thank you, Dr. Venugopal and Dr. Copeland. Next, we go on to a question and answer period. But for me to start off with that, I'd like to ask direct a question to Dr. Copeland. Dr. Copeland, you have shown some studies done in comparing our data with first world data, I should say. I'd like to explain, where do you think we should aim for? What are we falling short on, or what would you like to see happen in our part of the world to equalize the patient care with first world care?
Thank you, Dr. Bhoorasingh, for that question. I think there are, probably can separate into a few areas. Looking at the breast cancer mortality, looking at the breast cancer morbidity, and looking at research. Now, to really address the breast cancer mortality, obviously we need wide-based national breast cancer screening program, population education programs where we can increase the early detection of breast cancer in our population. If you look at some of the findings from the research as well, you find that breast cancer in our population is innately more aggressive. We have the high triple negative rates, we have high grade and that sort of thing. So a patient who presents, especially in the public system, based on our data, is an aggressive type of cancer with a already poor prognosis. Now, we need to have a system to receive that patient that offers a high standard of care, a multidisciplinary care, and to have essentially a center of excellence for oncology care for these patients, because they're coming in already with a relatively poor prognosis. The issues having to do with morbidity as well, and as Dr. Venugopal has shown, that even patients who do not qualify for breast conservative surgery and are treated with mastectomy, these patients can have breast reconstruction done to improve their overall quality of life. But that takes funding, because at KPH, we do not have, for example, implants and expanders readily available, and it is oftentimes prohibitive for the patients to purchase. So it's another thing that we need to look at in terms of the improving the morbidity. And finally, research. We're looking at starting a genetic research program for breast cancer patients at KPH. But a rough estimate, we're looking at about 3 to 4 million Jamaican dollars per year to fund that sort of research. But I think that is important when you look at the age distribution of our population. So I think those are the three main areas that I would like to see significant improvement in. Steps to decrease the mortality by increasing screening and awareness, and having a center of excellence where we can treat our patients better with multidisciplinary care, or more centers of excellence. and of course, decreasing the morbidity and having better research to understand our population.
Question to Dr. Venugopal. Raj, there are a number of patients who have breast implants put in to increase the bust size, even without breast cancer. Well, it's really quite popular these days. If you want to increase your bust size, then you go and you can choose what implant you put in. How do you suggest? Do you suggest to these patients they still have their breast tissue, they can still breast cancer? How do you follow your patients who have cosmetic surgery on the breast with implant in the long term?
Thank you, Dr. Bhoorasingh, for that question. The answer to that is that their method of screening is really no different from the other population that you and I see. So they are still to do self-breast examinations as well as their radiological imaging. Obviously, the technicians who do the mammogram will need to be aware and sensitive of the fact that they do have an implant. And in difficult cases, obviously, which is not a screening tool, the magnetic resonance imaging or MRI is the method of screening.
Okay, thank you for that, Dr. Venugopal. I have a question for Dr. Copeland. You spoke a bit about the the implication of genetic testing and what it means for the severity of disease. How available is genetic testing in Jamaica right now? Is it here? Is it affordable? Is it something? What do you see as the future of it? Will it be soon widely available, or just a select few?
Right. So, well, the short answer is that genetic testing is available locally. It's available in the privately. It's not available through government labs or public labs or that sort of thing. So it is also a bit prohibitive with some of the patients. Now, as I mentioned, the program that we're looking at is to actually fund genetic testing for the majority of our patients who qualify, who have breast cancer. Now, the program like that is about 3 to 4 million Jamaican dollars per year. So that requires institutional support and funding, perhaps through the ministry, because asking each patient to actually pay their portion for a genetic test, we found that we're not getting a lot of patients who can afford it, and hence the quality of the data that we'll get will likely to be poor. But it's extremely important because understanding the genetics allows us to treat the patients better, actually, because, for example, a lot of the patients who have, if they have a BRCA mutation, we would not offer them breast conservative surgery. We'd offer them a mastectomy, and in a lot of cases, we'd offer them bilateral mastectomy. There's also implication for that patient's relative as well that we have to bear in mind. With advancement in the understanding of breast cancer, there's even newer drugs that we can use in patients who have these mutations, and their overall outcome is actually better. So understanding more of the genetics is extremely important. Available in Jamaica privately, but the cost for a lot of the patients publicly is a little bit prohibitive.
Certainly very interesting. And I think that there are a lot of pathologies that are facing a similar challenge. As a urologist, and I can tell you that prostate cancer, we're looking at things in a similar light in terms of genomic testing and profiling and individualized treatment for our cancer patients. Dr. Venugopal, I have a question for you as well. Is there any evidence, any quality of life improvement for the persons who have immediate or early reconstruction following mastectomy? Does it really make a difference to the patients? Do they feel better? Do they do better? And aside from quality of life, are there any other endpoints that they improve in?
Thank you, Ray, for that great question. I think it was highlighted in one of the slides where I spoke about the psychological improvements, and that has been documented in multiple studies. So doing immediate reconstructions, the patient does not feel that loss of, a significant part of their identity. And there's actually objective scoring systems which are used in the study to quantitatively prove that the quality of life is actually better.
Thank you. We have a question from the audience participants, a question from Helen. What is the best practice tips in counseling patients regarding body image disturbance? I think I'll probably ask Dr. Venugopaul his opinion on that. Did you hear the question?
Yes,
What
sir.
is the best practice tips in counseling patients regarding body image disturbance?
Okay, well, I think that we could spend another day here talking about that problem. So, but in short, it is something that we often see in our practices, and it's important to actually, for us to identify the patients preoperatively and counsel them and really deal with that problem at a higher level. So it's a diagnosis that the physician should make, and it's usually not a problem that the patient themselves sees as a problem. And it's in medical terms, a body dysmorphic syndrome.
Thanks for that. One more question again from Helen. I'm not sure if it's the same Helen. How can one set up foundations in honor of breast cancer patients to raise awareness, funding, and support for families? Dr. Copeland, do you have any thoughts on that?
Well, actually, the Jamaica Cancer Society actually have foundations that can actually be used to do things like that. They do have quite a bit of support groups for patients who have been treated for breast cancer and who are recovering from breast cancer treatment. Some of these groups also include family members, and some of these patients, unfortunately, they have passed on. And the Jamaica Cancer Society Foundation is perhaps the best way to go in trying to set up a fund like this. Dr. Bhoorasingh, I think, wants to add something as well.
Yes, the Jamaica Cancer Society does have a group, Reach for Recovery, which it is suggested that you refer the patient to them before the surgery. It comprises mainly of cancer survivors, breast cancer survivors, who will counsel the patient or even pre-operatively, and even they visit them post-operatively in hospital. I'm not sure how active they are at the present, but it even goes as far as they have an annual event, Relay for Life, that takes place where the relatives and also survivors get together, and they have an annual vigil, including there's a run, and there are really talks given by survivors. Well, it hasn't happened. It's an annual event. It has happened recently. They have a chapter in Kingston, and there's another chapter in Montego Bay. But because of COVID, it has compromised those activities. But I'm sure there's plan to revitalize it when this is all over. Another question from Ellington. Is grading the same as stages in breast cancer? And maybe I can enlighten you regarding that. As Dr. Copeland mentioned about grading breast cancer, and I've also spoken about it in when I spoke this ductal carcinoma in situ. Grading is actually looking at the cell itself and the cell in relation to other tissues around it, and really give you an idea of how aggressive or how not aggressive the tumor will be. You can get grading from a biopsy, just taking a part of the tissue out, and the pathologist is a pathological analysis. The pathologist can tell you how aggressive the tumor is. You have a grading in ductal carcinoma and grading in, it's like having a fire, and you look at the fire and you say it's a big fire or a small fire or not a bad fire. But that's where stages come in now, because staging has to tell you how far the cancer has spread, whether it's confined to the breast alone, if it's confined to the nodes alone on the breast, or it has gone to distant organs. So the information you can get is like a fire again, just by put the fire out or even examining the building, you can see the extent of the damage of the fire. So staging you get from looking at the whole patient, but grading you can get it from looking at the tumors alone. And that goes for all cancers.
Great, thank you for that. Thanks for that clarification, Dr. Bhoorasingh. I think with that last question, we'll call an end to what has been a very fruitful and enlightening session. We've certainly taken quite a journey from the ancient Egyptians to the future of breast cancer in terms of the genomic profiling and individualized care of patients, and from the destructive surgery to reconstructive surgery. I thank you. I thank everyone for your time, and also for keeping with us with our delayed start, but it was certainly worth it. And it's been a very, very uplifting and insightful time. I am quite hopeful for the future of breast cancer surgery and care in Jamaica. So once again, I would like to thank everyone for your time, and I wish you all a good evening. Thank you.